Our special guest today is Dr. Todd Caze, and he's going to be talking to us on the topic of uncomplicating concussions. So Dr. Caze is a sports neuropsychologist and the owner of Caze Concussion Institute, located in Omaha, Nebraska. And he's going to give us a really cool presentation here today. If anybody does have questions, please drop them in the chat. We'll make sure and save those for the end. We'll also have some polls throughout the presentation with a little bit of audience participation here as we get going. So Todd, I'll let you go ahead and expand on the intro if you'd like and take us away.
Sure. Well, thank you all for taking time on Wednesday afternoon to learn a little bit more about concussions and the important role that you all have as coaches with that. What I will say is that we're kind of in a new era or new frontier of concussion. So for some of us growing up, it used to be I'm holding up one finger. How many fingers am I holding up? You only have 3 stars. Okay, great. Go ahead and go back out there. And so we didn't really treat this as a true injury. And the disservice is that while we saw other specialists emerge, such as elbow or knee or shoulder, we didn't necessarily have specialists in concussion. And that's starting to slowly shift. We're starting to now have people who've done 2-year fellowships in concussion. I'm one of those who have done that. And by the end of this cohort, there'll be maybe about 28 of us in the country who've done a 2-year fellowship on concussion. So a little bit of my background, my PhD's in clinical psychology with a concentration in neuropsychology from University of Nebraska-Lincoln. I was embedded in athletic medicine the entire time I was there, helping start their concussion protocol and database for research. I then went on and did a residency in adult neuropsychology at UCLA. Had the opportunity to work with Chris Caze. For those of you who may know that name, or neurobolic cascade of concussion, and then had the opportunity to be the inaugural fellow of Children's Health James Andrews Institute in Dallas, Texas. And what I joke is that even God himself can't stop football in Texas. So even in the midst of a pandemic, I was able to see over 2,000 concussions acutely. So when you see an injury that many times and that acutely, you have just a different understanding and appreciation. And my hope is to kind of translate some of that language into a way that is makes it a little bit less complicated for you all. What I will say before we dive into is, from a research standpoint, if you took all the articles on concussion from 1950 to 2000 and then compared it to 2000 to 2015, there was more articles in that 15-year span than the previous 50 years. And what's interesting is every subsequent year since 2015, what we've seen is more articles per year being published than that previous 15-year and previous 50-year window. So really what we're knowing and learning about this injury is happening right now in real time. And so what you may have heard even 3 or 4 years ago, or even maybe even last year, may be already outdated based on where the research is. And so this is an attempt to try to distill some of the research and give you some heuristics and general principles to guide your understanding of concussion. So as far as learning objectives for today, we're going to talk about the limits of current concussion tools. We're going to talk about some of the common impairments that occur to the ocular motor, the vestibular, and the autonomic system following concussion. And then we're going to identify your role as coaches and what that entails as far as concussion identification and also treatment. So as a way of introduction, 33 million children worldwide annually sustain a concussion, and the estimated yearly impact is 17 billion in healthcare costs. And we can assume that that number is only higher now as this goes on from 2017. At the end of all this, hopefully what will happen is you'll realize is as we work as a team, concussion in itself is really not that scary. And there's some really tangible things we can do to make this injury pretty manageable. So current most common assessment tools that we have in our bag are the SCAT, sideline concussion assessment tool, computerized testing. Most often it's impact, though SWAY is being used quite a bit as well too, and then symptom self-reporting. So the SCAT, which is currently the sideline concussion assessment tool, is in its 5th iteration. is what's recommended by the Concussion in Sport group. The sixth one is actually going to be released June 19th, when all of the consensus statements and articles that inform the consensus statement are released by British Journal of Sports Medicine Open Access. Currently, it's broken down into immediate or on the field assessment. What we know is that there's limitations to the SCAT. The consensus group even said itself that it's really only capturing so many modalities, and that's a limitation. And what's important from our end is that its sensitivity and specificity is greatly reduced each subsequent day after injury. And when we're talking about sensitivity, really what we're saying is, if there's 100 people who have a concussion, how good is our measure at telling us that all 100 people have a concussion? And specificity is telling us, okay, well, if there's 100 people who don't have a concussion, how good is our tool at telling us that those 100 people don't have a concussion? And in an ideal world, you're wanting to have something that has very high sensitivity and very high specificity. And what we know from the research is that the SCAT-5 actually does not have that great of sensitivity or specificity, especially the further out we get from the injury. So IMPACT was cognitive testing that was developed in response to the Pittsburgh Steelers head coach wanting a more objective measure for his concussed athletes. And you have to think about, in the time, in the 1990s, we weren't really doing much from a computerized standpoint, and most batteries to try to determine whether or not someone had a concussion usually took several hours. And so the brilliance of IMPACT at that time was that it would take about 20 to 30 minutes, and that it was computerized. So it was more accessible. You were able to very quickly assess whether or not an athlete had a concussion from a cognitive standpoint, and if they were showing improvements and healed from a cognitive standpoint. The challenge, as we had talked about earlier in the intro with the research, is that we know that what we know about concussion is the most evolved it's been right now. And the challenge is that the IMPACT has not been updated since the 1990s. And so the other thing is, baseline testing is often time consuming and often is not necessary. And again, we know that sensitivity and specificity is greatly reduced each subsequent day after injury. So another tool that is often used is the symptom self-report scales. These are often the driver of clinical decisions. Usually this is what helps us guide whether or not we're acutely removing someone from play. It helps us to determine whether or not we're progressing someone in return to play, and then often is the driver for determining clearance. We know that self-report symptom scales have limits as well too. So one of the constructs that we looked at for my dissertation was called anxiety sensitivity. And anxiety sensitivity asks questions like, when my heart's beating fast, I think that I'm having a heart attack. When I can't remember something, I think there's something wrong with my brain. And really where this construct came from was in the 1960s, they were trying to determine, why is it that some people have panic attacks, but other people don't? And what they found is this propensity to misinterpret sensations was the reason why some people with anxiety had panic attacks and others did not. And so anxiety sensitivity has robust research in helping us know that there's certain people who are more prone to struggling with withdrawal sensations from smoking. They're going to struggle with withdrawal sensations when they're trying to quit drinking. If they go through a stressful event like basic cadet training, they're more likely to develop a pathology as a response. And so what we did is we looked at musculoskeletal control injured adolescents versus concussed adolescents. And we matched them by age, gender, and days since injury. And we looked at, okay, so how is anxiety sensitivity, this personality trait, related to the symptoms that they endorse related to their injuries? And what's interesting is what we found is, for every 1 unit increase in anxiety sensitivity, there was a 4-unit increase in concussed symptoms reported. let me say that again. So for every 1 unit increase in anxiety sensitivity, there's a 4-unit increase in concussive symptoms, and that continued to progress as you went on. So the higher a person's anxiety sensitivity, the more symptoms they endorsed, both individually and then total symptom scales. And what that tells us is that really, personality factors could be contributing to someone reporting symptoms. What's also interesting is some of the studies that I've looked at people who are at quote unquote 0 symptoms, even at baseline. So what we know is that when we look at an adolescence, how many adolescents, they looked at how many adolescents would meet criteria for post-concussive syndrome just based on their baseline symptom reporting. And what they found is that 20% of males and 28% of females just at baseline in their symptom endorsing would meet criteria for post-concussive syndrome. What's also interesting is that only 34% of high school athletes and 40% of college athletes are actually at 0 symptoms at baseline. And what we know now with most of our laws currently, you have to be symptom-free in order to be, for sure, be cleared from concussion. And in a lot of states or schools, you have to be symptom-free to even begin return to play or physical activity. And we have to ask ourselves if most of the population is not at 0 symptoms at their baseline, are we basically just encouraging kids to lie about their symptoms? So what we're going to do is we're going to kind of take a bird's eye view here. So to obtain a bird's eye is to turn a blizzard into a breeze. So what we're going to do is we're going to talk about what a concussion is. And a concussion in its simplest form is a network disruption injury. These are some of the common networks that we know from research, and the ones that we're going to spend our time on is the autonomic, ocular, motor, and vestibular. And what I will say is this, is if there's nothing else you get from this talk, the more you can understand and appreciate the simplicity of this definition, the more profoundly you'll be able to actually understand this injury. And so by understanding that this is a network disruption injury and that there's multiple networks that are impacted after injury and that there's a range in which each network could be impacted for each individual athlete, it helps you to appreciate kind of some of the nuances or some of the oddities in symptom reporting or just impairments that you might see in the athletes that you work with. So let's talk about the autonomic system. So our autonomic system is heavily involved in pretty much, I joke, like all the things. So we have our sympathetic, our parasympathetic, our enteric as well. And it's involved in several processes. So our heart rate, our blood pressure, our breathing, our digestion, our sexual arousal. And it also helps with regulating our emotions. So let's do the next polling question. And I'll kind of prime this up. So imagine, if you will, that a bear stumbles upon a large quantity of cocaine and ingests this said cocaine and then comes barging through your walls. And this bear is basically the most apex predator there is in existence until eventually they keel over from the cocaine giving them a heart attack. All of us are going to have some sort of response. We're either going to fight it, we're either going to run from it, or we're going to play dead.
All right, you ready for some results?
Yeah, let's see what we got here.
All right, we've got, well, they're still coming in. We've got 12 people answered so far.
Cool. Looks like most people are running. I like it.
Yeah, it looks like 23% are fighting it, 62 are running, and then 15 are freezing or playing dead.
Yeah, and so what's important is that our autonomic it gives us a visceral response in the midst of distress. And the reason why that matters is, so think about from a concussion standpoint, anytime someone is dealing with a stressful situation, they're going to have some sort of visceral response. It also is what helps us with regulating emotions. So let's go ahead and close this polling. So common symptoms that you're going to see that are directly tied to the autonomic nervous system is you're going to see some fatigue. You're going to notice sleep disturbance, so maybe too much sleep, maybe too little sleep. And for your purposes, what's really important is there's going to be some exercise intolerance, and or symptoms are going to be exacerbated with physical activity. And then often you're going to see mood disturbance, and this usually kind of plays out as an increase in irritability. So let's look at some of the research on what we know about autonomic system and concussion. And what we know is that physical exercise actually accelerates recovery, and early intervention is actually the most effective. And this is across ages and modalities. So it doesn't matter if it's a treadmill, a bicycle, walking, doing aerobic activity, whatever it is, whatever gets you moving, it's going to be effective. And just getting the heart rate up as early as possible is what's most effective. And we'll kind of talk about some other research related to that. So what I will say is that the implications of the autonomic with concussion recovery is probably what's been researched the most in the last 2 to 3 years. And really what we're seeing is the surge of the importance of rest is not best, and we need to get people moving as quickly as possible. I just realized that as I said that, but we forgot to do slide 19, but we'll just do the polling question at 24. We're at a point now where we're actually starting to see clinical reviews and meta-analyses, and what they're showing is that it's actually doing early exercise, even if there is a little bit of symptom provocation, actually speeds up recovery and reduces the amount of symptoms that are reported. Some other studies, which are pretty fascinating, looked at the number of steps. And what they found is that more steps, so what they looked at is how many steps per day are you taking, how many times per week are you taking said amount of steps, and how does that relate to recovery time, how does that relate to sleep. And what they found is that those on average who took more steps, those on average who worked out more per week, those on average who spent more total minutes exercising, actually recovered from their concussion faster. And all of the groups that were more rigorous in exercise actually experienced better sleep and better mood on reported measures. There was actually just an article that came out last week that's not part of this slide that looked at, okay, what happens if you introduce exercise 0 to 2 days, 2 to 5 days, 5 to 7 days, 7 days out, and then not at all. And basically, if you go across each group, the earlier you introduce exercise, you basically are shaving off 5 days of recovery per group. So 0 to 2 days versus 3 to 7 days, they get better 5 days faster. This group gets better 5 days faster than the later group. So the longer out you are in introducing physical activity, the more problematic it becomes. The other thing that is often less appreciated is that I remember being on residency, and we would do these really extensive batteries for athletes who were retiring. And most of the feedback was spent on, hey, you know what, you actually have underlying ADHD or bipolar 1, bipolar 2, depression, and you've never needed medication because you are an athlete and you're constantly active and you're physically active. So now that you're taking away your natural medicine, what are you going to do to help regulate? And so a lot of times this is even just talking through developing some sort of structured routine exercise program. And so when you think about concussion and kind of some of our current policies, maybe the reason why some of our kids are experiencing anxiety or depression or a disturbance in mood following injury is simply because we're not allowing them to use their natural regulator for mood, which is physical activity, which is physical exercise. Now, we're not saying go out there and do, contact practice, putting them at risk for getting a second injury, but maybe we need to reconsider this notion of like, oh no, we shouldn't have them doing anything, and it's better for them long term from a concussion standpoint, but then also from a mood standpoint, just given the power that there was a study in British Journal of Sports Medicine that looked at just overall, no matter what pathology we're talking about, chronic pain, acute pain, whatever it may be, when we're looking at medications, we're looking at different interventions, which one is the most powerful? And by far, the strongest beta weight was physical activity, was exercise. And so that physical activity, just like it's vital in any other type of pathology or injury, all the more it's valuable for what we're talking about with a brain injury or concussion. Historically, our approach has always been that rest is best, but the research is actually really moving towards now that rest is not best, and some sort of physical activity, and honestly, however much physical activity that person can handle and tolerate without getting too symptomatic, that's what's in their best interest. That's actually what's going to accelerate recovery. And like I said, there was just an article published from the CARE Consortium, which is the largest study of concussed athletes, both collegiate and tactile. And again, what they found is if you're in that 0 to 2 day group where we're introducing physical activity, you actually are shaving off days in your recovery. And so, it's at a point where even when I see kids virtually, one of the first things that we're talking about with the families is like, hey, actually tomorrow, like I want you to go for a walk. I want you to, if that feels good, I want you to do a light run. So getting that physical activity going is actually what's going to help accelerate their recovery. Now let's talk about the ocular motor system. So in neuropsychology, usually it's not uncommon for neuropsychologists to kind of geek out about one specific system or network. And for me, it's always been the ocular motor system or vision system. I think it's kind of underappreciated how complex our visual system really is and how integral it's involved to actually just even integrate visual information in real time. And so from a concussion standpoint, there's really two main functions that we're looking at with ocular motor. So the first one helps us with controlling our eye movement. And then the second one helps us with integrating visual information. And so after injury, some common symptoms include blurred vision, headache. And it's important with concussion to realize like not all headaches are equal. So you always want to ask, well, what type of headache are you having? Is it a pressure? Is it throbbing? Is it shooting? And usually they're going to tell you it's ocular motor because they're going to say it's pressure. They may even kind of grab behind their eyes. They're going to start to complain about lights. They're going to even start noticing lights for the first time, or they may even report some fogginess as well. All right, let's talk about the vestibular system. So I kind of joke about this, like when I was doing a Google search, like this person clearly thought that this was majestic, that it should have been on a Pegasus and on a rainbow. And the vestibular system is quite remarkable, heavily involved with our brainstem and brain cortex. There's inner ear contributions as well. And really it's boiled down into kind of three main functions based off two cortical tracts. So it helps us with our ability to control our gaze, to control our gait when we're walking or running, and then to know where we are in space. And so after injury, you're going to see common symptoms such as dizziness, nausea, blurred vision, balance problems, and feeling foggy. It's about 50-50 whether or not people have heard of the VOMs. If we were to take this a step further and ask how often have you given the VOMs, usually that answer drops down pretty significantly. And what we need to appreciate about the VOMs is I'm going to get into some of the measurements and key takeaways, and then I'm going to backtrack a little bit and actually go through what the test looks like from an administration standpoint. So I'll go ahead and close this polling question. And what the research shows us is, from a measurement standpoint, the VOMS is actually very reliable. In its totality, it's really good at catching or detecting concussion. And then there's a very low false positive rate. So that means like very few students at baseline are going to score positive on the VOMS. In fact, in between studies, there's anywhere from as low as 3 to 5% of people who don't have a concussion will score positive on the VOMS. And that sensitivity and specificity is so much higher than any of the other tools that we have, markedly so, that we can have confidence that if we're using the VOMS, if we're able to provoke symptoms, that this person has a concussion. So we're going to walk through this. And since this is virtual, you're going to kind of do this on your own. And I'll try to have you guys be able to see from what I'm doing as well, too. So what you're doing initially is you're just trying to get a sense of, does this provoke symptoms for somebody? So you're just getting a rating from them, 0 to 10, 0 is nothing at all, 10 we're going to ER. What's headache for you right now? What's dizziness right now? What's nausea right now? What's fogginess for you right now? And so you start with that, and then you go through each of these tasks, and you're trying to see, okay, do these tasks provoke symptoms as we go? So the first task that you have them do is you have them look at their index finger, keeping their eyes on their index finger. They go across, they go up and down, and then they go across, and they go up and down. So I want you to go ahead and do that for yourself, just so you can get a sense of, what is it like to be moving my eyes like that and not be moving my head. So go ahead and look at the tip of your finger, go across, up and down, cross, up and down. And for those of you who have never used the VOMS before, while there might be some objective findings that you're looking for as you're having them move their eyes, really is what you're most concerned about is, can I provoke symptoms? So do they all of a sudden go from 0 symptoms to now they have a 1 or 2? Or if they come off the field and they say, I have a little bit of a headache, does this make their headache worse? And if it does, then we can have confidence, okay, this person has oculomotor disruption, this person has a concussion. The next one is, you're going to hold your fingers out in front of you at eye height, and you're just going to move your eyes back and forth as quickly as you can. So you're just going to go back and forth as quickly as you can. I just want you to orient yourself to, what does that feel like to be going back and forth as quickly as you can? What's interesting is the research shows us that you should be able to do that up to 20 times, no problem, with no symptoms. What's also interesting is that our eyes are limitless as far as how fast we can actually move our eyes. It's like any other muscle that we can develop. And what we know is that the best athletes in the world have the fastest eyes. So I'll give this story. My old fellowship supervisor covered Florida State, and they were doing some baseline stuff, VOMS, and what they were doing is just to kind of push the envelope a little bit. They wanted to count the number of saccades. So they would count 1, 2, 3, 4, 5, 6, back and forth, just to see, okay, in 10 seconds, how fast can an athlete's eyes move? What's interesting is they get to Devontae Freeman, and his eyes are moving so fast that they have to start counting every other. And his eyes are moving so fast, they actually have to record it, slow it down so they can count every other. And for those of you who are familiar with Devontae Freeman's career, he was a first-round draft pick at running back, and he made it to multiple Pro Bowls. And that makes sense from an adaptive standpoint. Think about how elite your eyes need to move as a running back in order to see holes, see blocks, cut quickly, disabsorb things. Your eyes are moving. They're just humming, basically. And so and we'll get into the snapshot stuff later. So what you're doing is you're just having them move their eyes back and forth. And a lot of times you're just having them move their eyes back and forth about 5 to 7 times. And if that's provoking symptoms, again, we can have confidence, okay, that person potentially has a concussion. Next, what you do is you go up and down, and we go up and down as quickly as you can. And go ahead and do that for yourself. What I will say is most people's vertical movements are much slower than their horizontal movements, just because our world really revolves around horizontal eye movements. Even if you think about reading, it's more horizontal than it is true up and down. Although it's interesting that now we have this generation, their eye movements are actually really good moving down, but they're awful moving up. So that's kind of a sociocultural kind of consideration. Next thing, what you're going to do is what's called convergence. So you just hold your finger out. So I want everyone to hold their finger out, extend your arm out as long as you can. And I want you to focus on the tip of your nail or finger, and you're going to slowly bring it towards your nose. And I want you to stop if you start to see two of your finger. So you're going to do that. And in an exam, what you're doing is you're doing that 3 times. And you're doing that because you're trying to see if there's fatiguing that emerges. The next thing that we're going to do, again, we're going to do this all together, is using a metronome, and you'll set at 180 beats per minute. You'll hold your thumb out like this, keep your eyes on your thumb. We're going to move our head back and forth. So let's go ahead and do that together. Go ahead and move your head back and forth. And stop. You'll see, okay, does that provoke symptoms? Then we hold our thumb up and we're going to go up and down. And then the last one, we can all kind of stand up as a break. So we stand up and our fingers, fingers out, keeping your eyes on your thumb. We're actually going to rotate at our trunk, 160 to 180. And so now we're just going back and forth, crossing the midline, keeping our eyes on your thumb. Now, what's interesting about this from a just like a face validity standpoint is it's important to think about, okay, what happens during pre-snap and the 3 to 5 seconds a quarterback has to throw the football? How quickly are their eyes moving? How quickly is their head moving? If they're starting to come under distress and they start to sprint out of the pocket, if a receiver is running at full speed and turns their head to try to catch the ball, think about how quickly they're processing and integrating information. What's interesting is that if you think about it from the metric of hertz, what we know is if we're walking, that's about 2 to 3 hertz, and a receiver sprinting full speed, turning for the ball, is running at anywhere from 5 to 6 hertz. And when we're doing the VOMs, we're never doing more than about 3 hertz. And we're doing it for a fraction of what they would actually be integrating. So if they're on a sideline and you're having them do these tasks and it provokes symptoms, you can have confidence that this person has a concussion, needs to be sat, and needs to be evaluated. And if you're interested in learning more about kind of the nuts and bolts of the administration of VOMs, I would just say, if you just do a Google search, how to administer the VOMs, usually there's a video that pops up on YouTube by University of Pittsburgh Medical Center, which is where the VOMs was created. So what is the coach's role in this injury? First and foremost, you are there to legitimize that this is a real injury. There is still some of the stigma that concussion is not real, it's something you can't see, you're just faking it. And so encouraging them that, hey, this is a real thing, this is something that is pretty serious, is important. Creating a culture of early reporting, which will result in faster recovery. So a high school that I covered this past year, a kid got injured. They went to their primary care doc, who doesn't see concussions all day, every day. And that person took about 6 weeks to recover. And so there was very quickly this culture of like, no, we can't get evaluated by Dr. Caze, we're going to be out for forever. And then what happened is once we were able to see someone and get them back a lot of times within a week, maybe 2 weeks max, all of a sudden by the end of the season, as we got closer to playoffs, we were able to, we had parents come, or we had the players themselves or their teammates come and report. And really what was vital in helping us shift that culture is that the head coach actually sent out an email to all the families and said, hey, this is who Dr. Caze is. This is why he's on our sidelines. This is why concussion matters. And ultimately, if you report early on, we can give you targeted treatment, which will result in faster recovery. If you have an athlete who is injured and they're at your practice, have them do physical activity. but also encourage them that, hey, it's okay to take a break when you get symptoms. Just let them calm down. You'll be good to go. The other thing is help them ramp up their physical activity. I think sometimes what happens is we hear a kid's got a concussion and we put on the kit gloves. And the reality is as long as that kid's not doing contact, and as long as there's not a risk of that kid hitting their head, it's really important to keep ramping up their heart rate. And really it serves as rehab or recovery for the autonomic. The other thing is to reinforce the importance of HEP. So the football team that we worked with, they would check in, hey, how's it going? I know you saw Dr. Caze, you're in concussion protocol. Yeah, how are you feeling? I'm just doing all right. Well, how often are you doing the home exercise program? I'm working on it. And they'd be like, look, we need you on Friday. Like you need to do this. We're not going to make you play if you're not ready, but doing the home exercise program, doing what the treatment protocol says is your best chance to be able to play. A lot of times too, even the coaches would be like, hey, let me see how many beats per minute you're up to with your home exercise program. So there was ways that they could kind of reinforce and leverage that role and that vital leadership role of coach to reinforce the treatment that's at hand. So that was a lot of information. That was fast and furious, but there'll be some polling questions at the end, but I do want to open it up to some questions or some Q&A.
I do have a question for you. In one of the early polling questions and during your presentation, you talked about rest or activity, quote, immediately after a concussion. Can you expand on how you would define immediately? Is that activity within the same day? Is that the next day? How would you define immediately?
Yeah, it kind of depends on when the injury happens, right? So if it's Friday night lights, like probably you're not going to do much physical activity that night. But I would say within the 24 hours of injury, you want to get some sort of physical activity going. And the more activity you're able to do, the better. The other thing that's challenging is that because this injury is so driven by symptoms, I think that sometimes we teach people that symptoms means shut down rather than symptoms means rest. And really we need to move towards symptoms just means rest, and rest doesn't mean completely. The rest doesn't mean you completely shut down, take a nap. Rest just means that you let the symptoms calm down and then you go back to that activity. So you think about it almost like an ankle sprain. Like you wouldn't just completely take them off of their ankles. You want them to be doing as much range of motion stuff as they can tolerate in the midst of also resting. So it's rest, rehab, rest, rehab, rest, rehab in order to kind of maximize recovery. You do blood testing for protein markers for concussion? No, we currently do not. What's interesting is so the VOMS is really good at catching concussion. From a biomarker standpoint, there is some promises with blood testing and protein markers, but I actually think that the most promising is saliva. If walking is good, is playing video games also good? So the video games is tricky. It depends on the dynamic of the video games, right? So if it's something that requires a lot of visual stuff, theoretically it's good for the ocular motor, but what it doesn't do is it doesn't get at the autonomic. And it seems like the research is showing us that the autonomic kind of primes the brain for that physical activity. As far as the phenotypes of concussion, what I'm going to say is this: it's kind of it's an easy way for us to overcook the injury. If we get too granular, then we're going to kind of struggle with just the general guiding principles of you got to get their heart rate going, you got to get the ocular motor vestibular going, and just kind of going from there. I will say that it's just there's even some of the phenotype research now all of a sudden they're saying that the profiles can overlap and there's different modifiers, and that's why I think it's just easier to take a more simplified approach of it's just simply a network disruption injury.
Awesome. Got another question for you in the chat, Todd. The question is, in football, I see players all the time. Nope. I see players all the time who take a hard hit, maybe complain that their head is sore, but don't show any other symptoms. We use the scat, which also might not flag any other issues. Should we still be sitting that player?
So yes, like when in doubt, sit them out, and a lot of state laws require that you do have to sit them out if you suspect a concussion. What I will say is this: is that if you're doing the challenge with most sideline assessment tools in its current form is it doesn't try to poke the bear. So think about if a player injures their knee, and again, you don't want me doing Lockman. I literally just do the brain up, but you do the Lockman to kind of see, okay, how can their knee handle distress in different parts or different aspects of movement with their knee. And if you're able to elicit or provoke symptoms or pain, you know, hey, there's something off with this person's knee. I think a lot of times why we think that this person doesn't necessarily have many symptoms is because we're not doing enough to really provoke symptoms. And the uncomfortable thing is that the scat in its current form doesn't actually provoke symptoms. It could be challenging, but it doesn't really get at it and poke the bear and say, okay, well, let's see how your ocular motor and your vestibular system is doing. I give this example. I was covering a lacrosse tournament, and there was a kid who just got rocked. And it was a showcase. And so, you know, dad and kid are arguing with me. No, I don't have a concussion. I start doing the bombs. Their eyes are fatiguing right away. It's very obvious they have one. They're like, no, we don't have one. I was like, well, you know, emotional liability is actually a sign of concussion. They're still arguing with me. So I just have the athlete doing the VMS, and I just have him do it for 30 seconds. And the kid starts swaying and almost falls over. And then finally the dad's like, okay, I get it. Like, yeah, he's out. And then I drove away to go evaluate another athlete, and he ends up throwing up. And you may say, oh, well, that was really cruel. But think about what would have happened if that kid would have went back out into lacrosse and kept playing. Now we're talking about potentially second impact syndrome. So I do think that, you know, you should use the bombs. You know, if you're not comfortable making a yes/no decision about sending them back in based on a negative bombs, I totally understand that. I would rather you err on the side of a false positive and be wrong than no, this person's good, and then send them back in. Let me see here.
Yeah, another question from the chat: as an active adult or as an athlete, if I receive, you know, a blow to the head and I feel concussed, can I implement the VOMS as a baseline test for myself, and then use it again if I feel like I've been concussed later?
Yeah. So what I will say is that, especially if you see somebody who specializes in concussion all day, every day, there's really not a need for baseline. Now, if you were wanting to do the bombs for yourself to see if it provokes symptoms, I would say that's not a bad idea, because it's a lot like an ankle sprain. So if you think about an ankle sprain, if you don't do targeted recovery on an ankle sprain in full range of motion, you probably are going to be fine 98% of the time. But then all of a sudden, if you really stress the limits of your ankle and try to train for a marathon, you've never run a marathon before, you might start noticing, oh man, like, you know, that kind of hurts the way it hurt when I first sprained or tweaked it. The same can happen with concussion. It's not until we're in these very heavily involved ocular motor and vestibular or several networks at once integration type environments that all of a sudden we start to get symptoms. And so, you know, again, without doing an exam, you know, you might be getting headaches, or you might be noticing symptoms that emerge in certain situations. And you may think that they're just, that's just, you know, that's just a headache, but it could actually be because you haven't done targeted rehab on the ocular motor and vestibular. So again, I would say I would put myself through the test just to see, hey, am I provoking symptoms? And if they are, then, you know, go see a specialist. And there's probably just maybe a home exercise program or a couple PT visits, and you'll be kind of squared away. So
we got one more question. We've got a little bit of time here. So what are some strategies to create and curate buy-in for the concussion protocols currently in place at your school or athletics programs? Many times, unless the hit is witnessed, self-reporting is limited.
Yeah, so, you know, I'll be very transparent. The challenge is this is the only injury with legislation around it. And I think that we sometimes underestimate the unintended consequences of that. And so think about if we had legislation around ACL, we probably wouldn't even have sports. And so the challenge is that a lot of schools' policies probably are in desperate need of an update. They were written in response to the law that came out, anywhere from 10 to 15 years ago, and a lot of times it's not current with where the research is. And the hard part is for some schools, not necessarily all of them, concussion protocol is viewed by athletes as purgatory. And so what I would say is that the way that you create buy-in is that you're constantly always trying to update it, and you're trying to find ways to help the athlete get back to sport as quickly and safely as possible. And if you're able to do that, that helps. But then again, I think part of the buy-in is you need everyone who's around that athlete to be creating a culture of, like if you don't report this and you get injured again, like now you're talking about being out for potentially the entire season or the rest of your life. It's not necessarily scaring them, but it's kind of letting them understand the gravity of the situation if you don't. But again, I think there is a little bit of an onus on our end we got to make these protocols not so laborious and take forever. And I think once we can demonstrate that, hey, we can get your kids back on the field safely and quickly, that kind of dominoes into kids trusting the process more as well too. I did want to highlight, Caze Concussion Institute, we do have aspirations to be a nationwide provider. So through SciPac, we actually are able to see people currently in 38 states and counting. And every year there's about another 3 or 4 states that are added. We do mostly virtual just because we understand the importance of access and just knowing that not everyone has access to specialty care. So this information will be available for you all if you're interested in just utilizing us as a resource, or if there's ways that we could be a resource for you all going forward, whether it's the teams you work with or organizations you work with, please don't hesitate to reach out.
All right. Thank you so much, Todd. Really appreciate it. We'll record. This has been recorded, so we'll edit it and make it available on our YouTube channel, and we'll distribute it through social and all those other channels as well. If anybody has more questions, feel free to contact Caze Concussion Institute. Actually, you can email Todd directly if you've got his email here. And then you can also email us at support@voltathletics.com if you have any questions as well.